condition. More often seen in children also, even in adults also, and here the patient or the parent complains, especially in children, there's a gap between the upper and the lower teeth. I can't incise, I can't eat with my front teeth, and that's the condition, open bite. The open bite could be dental, which is more often due to habits, or it could be skeletal, where the jaw bases have become divergent. It could be in the anterior teeth, most often it is in the anterior teeth, but it could be in the posterior because of a lateral tongue thrust. So here, a clinical picture, and typically this type of open bite, as seen in the mixed dentition, is because of thumb sucking habit. The thumb rests on the lower incisors, it takes a fulcrum over there and proclines the upper anterior, causing a typical open bite. So when such is the open bite, one has to assure to the patient, find out whether it is compulsive, non-compulsive, meaningful, non-meaningful, and then accordingly, the management of this patient has to be done with habit-breaking appliance or tongue spikes, which are smaller in size, just to take out the satisfaction of sucking when the patient places the thumb in the mouth. But you can open bite like this. Upper procline, lower procline, and a typical open bite, which is often due to tongue thrusting habit. So you can treat it with a removal appliance by giving tongue spikes, or it can be treated even with the fixed appliance. Now this is a growing patient. The patient has a skeletal open bite, a high mandibular plane angle. The palatal plane to mandibular plane angle is increased. So in that cases, it is because of the divergence of the mandible, of the palatal plane to the mandibular plane. Often the maxillary plane is tipped upward anteriorly. A small ramus is there. And when it is in a growing patient, then orthopedic appliances like headgear can be given. So a high pull to vertical pull headgear can be given in that case with a force of around 400 grams. And a posterior bite planes also helps to intrude or rather to prevent extrusion of the posterior segment when the patient is growing, so that the skeletal structures balance to this position, new position. It is also called as skeletal open bite, is also called as Apertognathia. This is a skeletal open bite in adults. So along with the fixed appliance, a fixed habit-breaking appliance is given to train the tongue the correct position, so that when the open bite is closed after fixed appliance therapy, then it doesn't reopen. The open bite relapse doesn't take place. Often it is associated with proclination. So extractions are done, as can be seen in this case. 4 extractions are done. So with retraction, the open bite will close, and with the control of the habit also, the open bite will close and will be maintained. The corrections will be maintained. The figure at the bottom can be seen over here, a fixed appliance with a box elastic. When the elastic is worn like this, it is called as a box elastic to close the open bite. In adults, along with the fixed appliance, an implant-assisted posterior segment intrusion is carried out. So implants are placed, or the mini screws are placed between the first molar and the second molar, and then intrusion of the posterior dentition is carried out. So with that intrusion of the posteriors, the bite in the anteriors will close, as can be seen over here. If it is a skeletal open bite, severe form falls within the envelope of surgery, then in that cases, the superior impaction, Leaffoot 1 osteotomy with superior impaction of the maxilla is done. But just see the cut. The cut is not given uniform. More in the posterior, the bone is removed, less in the anteriors. So more intrusion of the posterior segment will be carried out, so that the open bite will close with auto-rotation of the mandible. Often these open bites are with class 3 malocclusions, and then in such cases a bi-jaw, Leaffoot 1, as well as mandibular setback, BSSO with mandibular setback, with convergence of the jaw bases to close the divergence has to be done. So that the surgical management of open bite. This is how the mock surgery is carried out. For example, in this patient, a 5 mm of superior impaction was to be done, and the surgery carried out after mock surgery. Retention, open bite tends to relapse because tongue doesn't adapt so fast. It needs a reminder. Therefore, in a Hawley's retainer, either a habit-breaking reminder can be given, like a bit in the incisio-papilla region, or tongue spikes can be placed so that the tongue is trained a correct position, learns a correct position, and the open bite relapse doesn't take place. Or if intrusion of the posterior segment is carried out, then Hawley's plate with the posterior bite plane should be given as a retainer for long term. Now, opposite of deep open bite is a deep bite, where you cannot see the lower anteriors. So deep bites are often spoken in terms of percentage. How much is the visibility of the lower anterior? For example, here, the lower anteriors are not visible at all. So that is 100% deep bite. So here you can see, this deep bite is because of retroclination of the upper incisors. When the upper incisors retrocline, the bite deepens, and therefore they are to be proclined and intruded, as can be seen in this figure. A utility arch, a protraction utility arch is given in a fixed appliance, which will procline the anteriors and intrude it, and then the deep bite can be corrected. So to correct a deep bite, either intrusion of the anterior teeth or extrusion of the posterior teeth, which is carried out in a growing child, or both, so that the curve of P is leveled, has to be done. So this is another case, 100% deep bite, permanent dentition, where again with a fixed appliance, the bite is opened up, bends are given in the arch wire, curve of P arch wire is given, and the bite is opened up. And when a bite is opened up by proclination, you get an overjet. So in order to correct this overjet, the mandible has to be jumped, and in this case, a fixed functional has been given. Surgical management of deep bite. Often the deep bite is with class 2 malocclusions. So when it is with class 2 malocclusion, it will be taken with class 2 malocclusions. But when it is because of the extrusion of the anteriors, the lower anteriors, in this case, as can be seen, then in such cases, lower anterior dentoalveolar segmental osteotomy is carried out. Retention. A Hawley's retainer with an anterior bite plane should be given to prevent further extrusion of the lower anteriors and to control the eruption of the lower anteriors. Now you have another situation. A patient complaining of lower teeth forward, or he may complain that a maxillary teeth is placed lingual to the lower anteriors. So this is a crossbite condition, a reverse overjet condition, which could be anterior, which could be in the posterior teeth. It could be skeletal, it could be dental, it could be functional. Functional means when the patient takes the mandible from CR to CO position, centric occlusion position, because of some prematurity, the anterior tooth goes into crossbite. So in such cases, the occlusal prematurity has to be removed, occlusal equilibration to be done, and then the crossbite gets corrected. So here, the incisor, central incisor erupting just at the age of 7 years, and you can see the central incisor is erupting lingual to the mandibular incisor. So with a simple mechanics or a simple management by a tongue blade therapy, the patient can be asked to hold an ice cream stick 1 to 2 hours in a day for a shorter duration. And within 15 days to 3 weeks, this incisor will get a labial force, so the crossbite will get corrected. Or even a lower inclined plane can be cemented. It has an inclination of 45 degrees that will guide the eruption of this lingually erupting central incisor to a labial position. Often our removable appliances work beautifully. As can be seen over here, our central incisor is in crossbite. So we give a Z spring from inside. So when the Z-spring is given from inside, you need to disocclude it. Then only that incisor will move labially. So how it is disoccluded? By giving a posterior bite plane. So the posterior bite plane with the Z-spring also covered with acrylic so as to prevent the distortion of the Z-spring. And the active on the arm of the Z-spring is well in contact with the palatal surface of the central incisors, and it corrects the Z-spring, the crossbite within a short duration if the patient wears the appliance regularly. Even jack screws, which we use for expansion, can be used in this fashion so as to correct crossbite, and it is given along with a posterior bite plane. Always when an incisor or the anteriors are in crossbite, you need to disocclude it so that that labial force given by that lingual spring or a screw will work. So a posterior bite plane should be given. Now when it is a unilateral posterior crossbite, when whole of the maxillary posteriors, the premolar and the molars, are in crossbite. Here you can see the premolar and the molar is in crossbite. Now in such cases, either a removable appliance with a coffin spring can be given, or a W arch, or which is called as a bihelix, can be given, which can be activated unilaterally, and one can correct the crossbite. Even a quadhelix can be given. Quadhelix has an advantage that you can bring about anterior expansion, you can bring about posterior expansion, you can bring about a unilateral expansion, which is seen in the figure over here, the B. Or an expansion screw can be given, and the screw position should be such that the segment which is to be moved, it should be towards it. Now the crossbite could be bilateral, both in a centric occlusion and a centric relation position. There is a crossbite which is bilateral. So in such cases, we use an expansion screw or a Hyrex expander which works on the reciprocal anchorage, and both the segments are moved buccally. So if in adults the maxilla is deficient in the transverse dimension, it is constricted, then there is a resistance of the circummaxillary sutures and the mid-palatine suture to expand it. So in adults, a surgically assisted rapid maxillary expansion is done. The cut is given in the mid-palatal suture so as to reduce its resistance, and then a Hyrex expander is placed. So it works then with the least resistance from the mid-palatal suture, and the expansion can be carried out. So it is called as a SARME. Now there could be a condition where the whole of the posterior segment would be placed buccal to the mandibular posterior, and this is called as a Scissorbite. So in such cases, cross elastics are given from the buccal of the maxillary posteriors to the lingual of the mandibular posterior, and by disoccluding. So on the left side you can see a posterior bite plane is given, which has disoccluded so that the elastics brings the inclination to normal to a good fit of the posterior teeth. Now retention protocol, crossbites do not need a retention, because a tooth which has been brought labially, if there is a good overjet and overbite, will never try to go back into its original position. For example, the incisors, the lower incisors will never allow it to go back. But when the posterior crossbites are corrected by expansion appliances, then we need to give it for 2 to 3 months, the stabilization period, that is, so that a good fit of the posterior teeth takes place. When a good intercuspation is there in the posterior teeth, that is a natural aid of retention. Good occlusion is a potent factor in maintaining the corrections. So that should be achieved, and then no retention is required.